Hello everybody. Today we are going to discuss about ventilator associated pneumonia. So ventilator associated pneumonia is defined as pneumonia that occurs 48 hours to 72 occurs 48 to 72 hours or thereafter following endotracheal intubation, characterized by presence of new or progressive infiltrate, signs of systemic infection like fever, altered WBC, change in sputum characteristic and detection of causative agent. So VAP contributes to approximately half of all cases of hospital-acquired pneumonia. VAP is estimated to occur in 9 to 27% of mechanically ventilated patients, with highest risk being early in the course of hospitalization. It is the second most common nosocomial infection in intensive care unit and is most common in mechanically ventilated patients. So ventilator-associated pneumonia rates range from 1.2 to 8.5 per 1,000 ventilator days and are reliant on definition used for diagnosis. Risk for VAP is greatest during the first 5 days of mechanical ventilation, with mean duration between intubation and development of VAP being 3.3 days. The risk declined to 2% per day between 5 to 10 days of ventilation and 1% per day thereafter. Early studies place the attributable mortality for VAP at between 33 to 50%, but this rate is variable and relies heavily on underlying medical illness. Over the years, the attributable risk of death has decreased and is more recently estimated at 9 to 13%, largely because implementation of preventive strategies. Approximately 50% of all antibiotics administered in ICU are treatment of VAP. So the early onset VAP is defined as pneumonia that occurs within 4 days, and this is usually attributable to antibiotic sensitive pathogen, where late onset VAP is more likely caused by multi-drug resistant bacteria and emerged after 4 days of intubation. Thus, VAP poses the great implication in endotracheally intubated adult patients in ICU worldwide and lead to the increased adverse outcome and healthcare cost. Independent risk factor for development of VAP are male sex, admission for trauma, intermediate underlying disease severity. Regarding pathogenesis, the complex interplay between endotracheal tube, presence of risk factor, and virulence of invading bacteria boost immunity largely determine the development of VAP. The presence of endotracheal tube is by far the most important risk factor, resulting in the violation of natural defense mechanism, that is cough reflex of glottis and larynx against microaspiration around the cuff of the tube. Infectious bacteria obtain the direct access to the lower respiratory tract via microaspiration, which can occur during intubation itself. Development of biofilm laden with bacteria, typically gram-negative bacteria and fungal species, within endotracheal tube, pooling and trickling of secretion around the cuff, impairment of mucociliary clearance of secretions with gravity dependence of mucus flow within the airway. Pathogenic material can also collect in surrounding anatomical structure such as stomach, sinuses, nasopharynx, oropharynx with replacement of normal flora by more virulent strain. This bacterium-enriched material is also constantly thrust forward by positive pressure exerted by the ventilator. Whereas reintubation following extubation increases VAP rate, and the use of NIV has been associated with significantly lower VAP. Host factors such as severity of underlying disease, previous surgery, antibiotic exposure have all been implicated as a risk factor for development of VAP. In addition, it has recently been noted that critically ill patients may have impaired phagocytosis and behave as functionally immunosuppressed even prior to the emergence of nosocomial infection. This effect is attributed to the detrimental action of anaphylotoxins like C5A, which impair neutrophil phagocytic activity and impair phagocytosis by neutrophils. More recently, combined dysfunction of T cell monocyte neutrophil has been noted to predict acquisition of nosocomial infection. For example, elevation of regulatory T cells, monocyte deactivation, neutrophil dysfunction have cumulatively shown promise in predicting infection in critically ill population as compared to healthy controls. Regarding microbiology, the type of organism that causes VAP usually depends on duration of mechanical ventilation. In general, early VAP is caused by pathogens that are sensitive to antibiotic, where late VAP is caused by multi-drug resistant and more difficult to treat bacteria. However, this is by no means a rule and merely guide to initiate antibiotic therapy until further clinical information is available. Typically, bacteria causing early onset VAP include Streptococcus pneumoniae, Haemophilus influenzae, MSSA, antibiotic sensitive enteric gram-negative bacilli, E. coli, Klebsiella pneumoniae, Enterobacter species, Proteus species, Serratia marcescens. Culprit of late bag include MDR bacteria such as MRSA, Acinetobacter, Pseudomonas aeruginosa, and ESP. The exact prevalence of MDR is variable between the institution and also within the institution. Patient with history of hospital admission for more than 2 days in past 90 days, nursing home resident, patient receiving chemotherapy or antibiotics in last 30 days, patient undergoing hemodialysis at outpatient center are susceptible to drug-resistant bacteria. Commonly found bacteria in the oropharynx can attain clinically significant number in lower areas. These bacteria include Streptococcus viridian, Corynebacterium, Coagulus negative Staphylococcus, Neisseria species. Frequently, VAP is due to polymicrobial infection. VAP from fungal and viral causes has very low incidence, especially in immunocompetent hosts. Pathogen causing VAP and their frequency and their possible mode of MDR, if possible, if any, are listed below. Like Pseudomonas contributes 24.4% of VAP, and mode of drug resistance is the upregulation of efflux pump, decreased expression of outer membrane pouring channel, acquisition of plasmid mediated metallo-beta lactamase. Then Staphylococcus aureus, 20.4% of which more than 50% is MRSA. And the mode of MDR resistance is production of penicillin binding protein with reduced affinity for beta lactam antibiotic encoded by MEK gene. Then Enterobacteriaceae, the percentage 14.1%. It is plasmid mediated production of ASBL, plasmid mediated AMSA enzyme. It includes bacteria like Klebsiella, E. coli, Proteus, Enterobacter, Serratia, Citrobacter. Then Streptococcus species contribute to 12.1%, Haemophilus species 9.8%, and then Acinetobacter species 7.9%, Neisseria 2.6%, Stenotrophoма maltophilia 1.7%, Coagulus negative Staphylococcus 1.4%, and others 4.7% include Corynebacterium, Moraxella, Enterococcus, and fungi. Now, regarding diagnosis, at the present time, there is no universally accepted gold standard diagnostic criteria for VAP, and several clinical methods have been recommended, but none have needed sensitivity or specificity to accurately identify these diseases. Daily bedside evaluation in conjugation with the chest radiography can only be suggestive of presence and absence of VAP, but not defined. Clinical diagnosis of VAP can still miss about a third of VAP in ICU, comparable to autopsy finding, and can incorrectly diagnose more than half of the patient, likely due to poor interobservable agreement between the clinical criteria. Postmortem studies comparing VAP diagnosis with clinical criteria showed 69% sensitivity, 75% specificity in comparison to autopsy finding. American Thoracic Society, Infectious Disease Society of America guidelines recommending obtaining lower respiratory tract sample for culture and microbiology. Analysis of this sample can be quantitative and qualitative. The guideline also allow use of tracheal aspirate for their negative predictive value. Johnson et al. Describe clinical criteria for diagnosis of VAP as follows. Clinical pulmonary infection score takes into account clinical, physiological, microbiological, and radiological evidence to allow numerical value to predict the presence or absence of VAP. The score can range between 0 and 12, with score of more than 6 showing good correlation with presence of VAP. Despite the clinical popularity of CPSI, debate continues regarding its diagnostic validity. On one meta-analysis of 13 studies evaluating accuracy of CPIS uh, in diagnosing VAP, reported pool estimate of sensitivity and specificity for CPIS at 65% and 62%. Despite its apparent straightforward calculation, inter-observer variability in CPIS calculation remains substantial, jeopardizing its routine use in clinical trials. The criteria used to calculate CPIS only time-dependent. Changes in the PaO to FiO2 ratio early in VAP may provide some predictive power for VAP outcomes in clinical trial, namely clinical failure and mortality. However, trial by Singh and colleagues demonstrated that CPIS is an effective clinical tool for determining whether to stop or continue antibiotic for longer than 3 days. In study, antibiotics were discontinued at day 3 for patients who had been randomized to receive ciprofloxacin instead of standard care if their CPSI remained less than or equal to 6. Mortality and length of ICU did not differ despite the short duration and lower cost of antimicrobial therapy in the experimental compared to standard arm, and the development of antimicrobial resistance was lower among patients whose antibiotics were discontinued compared to those who received standard of care. The new or progressive radiographic consolidation will infiltrate. In addition, at least 2 of the following, like temperature more than 38, leukocytosis, murder, that is WBC more than 12,000, or leukopenia, that is WBC count less than 4,000, presence of purulent secretion. So this is clinical pulmonary infection score, which include temperature, which if it is 36 to 38, 0.38 to 38.5 to 38.9 to 1 point, bit less than 36 or more than 39, 2 point. Then leukocyte should be between 4,000 to 11. If less than 4,000 or more than 11,000, then 1 score. If more than 500 band cells, then 2 score. Tracheal secretion, if no absent, then 0. Mild or non-purulent, 1. If purulent, then 2. Then regarding radiographic finding on chest radiography, no filtrate 1, diffuse patchy infiltrate 1, localized infiltrate 2. Then regarding culture results, no or mild growth 1, moderate or florid growth 1, no growth is 0, moderate or florid growth 1, moderate or florid growth with pathogen consistent with the gram stain 2. Then regarding oxygenation status, if it is more than 240 or ARDS 0, if it is less than 240 or absence of ARDS 2. Then respiratory samples can be obtained using several techniques. The ATS and ITSA guideline note that the use of bronchoscopic bacteriological strategy has been shown to reduce 14-day mortality when compared to clinical strategy. When samples are obtained by BAL technique, that is BAL, mini BAL, or a protracted specimen brushing. The diagnostic threshold is 10 raised to 3 colony forming unit for protected specimen brushing or 10 raised to 4 colony forming unit for BAL. In one multicentered status, BAL and protected specimen brushing, this diagnosis was associated with significantly more antibiotic free days compared to guideline based clinical diagnosis alone. And this study also demonstrates short-term mortality benefit in BAL and PSP group. Now, the more recent evidence from Canadian clinical trial study of 740 suspected VAC patients randomized to the BAL and tracheal suctioning suggested that similar clinical outcome and overall use of antibiotic is observed when either BAL with quantitative culture or endotracheal aspiration with non-quantitative culture is used for diagnosis. So endotracheal aspirate, it is easier to obtain, does not require provider involvement. BAL requires bronchoscopic guidance. Then mini BAL perform blind, that is without bronchoscopic guidance. Then protected specimen brush utilizes brush at the tip of catheter, which is rubbed against bronchial wall. Once specimen is obtained, the sample is sent for gram stain culture and sensitivity. So gram stain can provide crucial initial clues to the type of organism, whether or not material is purulent. The purulent material here is defined as more than 25 or equal more than or equal to 25 neutrophils or less than or equal to 10 squamous cell epithelial cell per low power field. Culture report can be reported as semi-quantitative or quantitative value. Semi-quantitative values obtained by endotracheal sampling are considered positive when agar growth is moderate or heavy, and quantitative positivity is defined as more than 10 raised to 5 colony forming unit. Exact speciation of pathogen bacteria and their sensitivity of antibiotic can take few days but provides invaluable information. Mechanically ventilated patient in ICU receives frequent chest X-rays, and presence of infiltrate and consolidation is considered part of diagnostic criteria and is widely used. There are several clinical conditions that have radiographic appearance similar to the VAC. This condition commonly encountered in mechanically ventilated patients, and it include aspiration, chemical pneumonitis, atelectasis, congestive heart failure, ARDS, pleural effusion, intravalvular hemorrhage. Hence, reliance on chest radiography for diagnosis of VAP is not advised. There is poor correlation between radiological signs and histopathological diagnosis of VAP. Sensitivity and specificity of presence of infiltrate on chest X-ray is not encouraged. On the flip side, negative predictive value of infiltrate may have clinical utility. In meta-analysis by Klumpas, the presence and absence of fever, elevated WBC, purulent secretion did not substantially predict the probability of infection. However, the absence of new infiltrate on plain radiograph showed lowered the likelihood of VAP. So VAP must be differentiated from tracheobronchitis. Clinical feature of the disease can overlap, but only VAP will demonstrate presence of hypoxia and presence of infiltrate consolidation on chest radiograph. Recently, the CDC rolled out new surveillance criteria for possible and probable VAP. The goals were to capture the common complication of ventilator care and to improve objectivity of surveillance to allow comparability across the center for public reporting and minimizing gain. So, per these new criteria, the period of at least 2 days of stable or decreasing ventilator setting, that is minimum peak or fraction of impaired FiO2, followed by consistently higher setting, for at least 2 additional calendar days is required before a patient can be said to have ventilator associated condition. Most ventilator associated conditions are attributable to pneumonia, pulmonary edema, atelectasis, or ARDS, which all have very well researched prevention and management strategies. Signs of infection and inflammation, that is abnormal temperature or WBC, and administration of one or more new antibiotic for at least 4 days classify the patient as infection related ventilator associated complication. And the presence of purulent secretion and the pathogenic culture data will label the patient as possible or probable VAP. The patient with this inflammation, this infection related ventilator associated condition and purulent secretion alone or pathogenic culture alone have possible VAP. Those with both purulent secretion and positive quantitative and semi-quantitative culture have probable VAP. The probable pneumonia is defined by suggestive histopathological feature, positive pleural fluid culture, diagnostic test for Legionella, and selected viruses. Chest radiograph findings have been excluded in select new criteria because of their subjectivity without increased accuracy. This is not intended to reduce the role of radiography in clinical care. At the time, new CDC algorithm is for surveillance purpose only. Now, regarding treatment, selecting appropriate antibiotic depend upon the duration of mechanical ventilation. Late onset VAP, that is more than 4 days, required broad spectrum antibiotic, whereas early onset VAP, that is less than 4 days, can be treated with limited spectrum antibiotic. Updated local antibiogram for each hospital and each ICU based on local bacteriological pattern and susceptibilities is essential to guide optimally dosed initial empirical therapy. With any empirical antibiotic regimen, de-escalation is the key to reduce emergence of resistance. Delays in the initiation of antibiotic treatment may add to excess mortality risk with VAP. Owing to the high rate of resistance to monotherapy observed with Pseudomonas aeruginosa, combination therapy is always recommended. Acinetobacter species respond best to carbapenem, colistin, poly B, ampicillin, and sulbactam. Although MDR organisms are usually associated with late onset VAP, recent evidence suggests that they are increasingly associated with early VAP as well. The role of inhaled antibiotic in the setting of failure of systemic antibiotic is unclear. The usual duration for the treatment of early VAP is 8 days, longer in case of late VAP and if MDR organisms are suspected or added. Despite therapy, if no response is observed, it may be prudent to reconsider the diagnosis, reassess the organism being treated, or search for other reason for symptoms and signs. Because of the challenges associated with the diagnosis of PAP, especially in the early course, the ITSA and ATS guideline highlighted the importance of reassessing patient at 48 to 72 hours once pertinent data are available to determine whether the patient should continue antibiotic for VAP or whether alternative diagnosis should be pursued. In one study, Sovada et al. Found that half of the empirical antibiotic use for VAP in 2 surgical ICUs was prescribed for patients without pneumonia. So this is the recommendation for initial and empirical therapy. So for early onset VAP, second, third generation cephalosporin, that is ceftriaxone 2 gram daily, cefuroxime 1.5 gram every 8 hourly, cefotaxime 2 gram every 8 hourly, or fluoroquinolones we can prescribe, that is levofloxacin 750 mg daily, moxifloxacin 400 mg daily, or ampicillin plus beta-lactamase inhibitor, that is ampicillin sulbactam 3 gram every 8 hourly, or ertapenem 1 gram daily. Then for late onset VAP, we can prescribe cephalosporin, that is cefepime 1 to 2 gram every 8 hourly, ceftazidime 2 gram every 8 hourly, or carbapenem, imipenem silastine 500 mg every 8 hourly or 1 gram every 8 hourly, meropenem 1 gram every 8 hourly, or beta-lactam inhibitor, that is piperacillin plus tazobactam 4.5 gram every 6 hours, plus aminoglycoside, that is amikacin 20 mg per kg per day, gentamicin 7 mg per kg per day, tobramycin 7 mg per kg per day, or anti-pseudomonal fluoroquinolones like ciprofloxacin 400 mg every 8 hours, levofloxacin 750 mg daily, plus coverage for MRSA like vancomycin 15 mg per kg every 12 hours, linezolid 600 mg every 12 hours. Then for Pseudomonas aeruginosa, double coverage is recommended. For Acinetobacter species, carbapenem, that is imipenem silastine 1 gram every 8th hour, meropenem 1 gram every 8th hour, or beta-lactam, that is beta-lactam or beta-lactamase inhibitor, that is ampicillin plus sulbactam 3 gram every 8th hour, or tigecycline 100 mg loading and then 50 mg every 12 hourly. Then ESBL, which is treated by carbapenem, that is imipenem silastine 1 gram every 8th hourly, meropenem 1 gram every 8th hourly. If it is fungal infection, it can be treated with fluconazole 800 mg every 12 hourly, caspofungin 70 mg loading, then 50 mg daily, voriconazole 4 mg per kg every 12 hours. If it is Legionella, then we can treat with macrolides and fluoroquinolones. Now, regarding prevention, there are multiple recommended measures for the prevention of the VAP, and the institutions in the ICU may observe the reduction of VAP rate by utilizing VAP bundle approach. A five-element institute of healthcare VAP bundle include head of bed elevation, oral care with chlorhexidine, stress ulcer prophylaxis, deep vein thrombosis prophylaxis, daily sedation assessment, spontaneous breathing trial. Each of these elements have shown to reduce incidence of VAP, although the quality of evidence supporting effectiveness and importance of each intervention has been questioned. So this VAP bundle include head and elevation, oral care with the chlorhexidine, stress ulcer prophylaxis, deep vein thrombus prophylaxis, daily sedation assessment, and spontaneous breathing trial. So there is a significant reduction in the VAP rate, antibiotic use, and MRSA acquisition. There was no reduction, however, in duration of mechanical ventilation or 5-day admission. So suggested measure for prevention of the VAP include alcohol-based hand washing policy, early discontinuation of invasive device like then reduce reintubation rate, prolong use of oropharyngeal nasopharyngeal feeding tube, semi-recumbent position, endotracheal tube cuff pressure is 20, early tracheostomy, small bowel feeding instead of gastric feeding, then prophylactic antibiotic. And institution focus measure include surveillance program for pathogen profiling, frequent education program to reduce unnecessarily antibiotic prescription, propagate use of NIV, endotracheal tubes with potential benefit like polyethylene cuff ETT, silver antibiotic coated ETT, aspiration of subglottic secretion, maintain policy for oral decontamination, selective digestive decontamination, early weaning and extubation, daily sedation hold, then preference on using heat moisture exchange over heater humidifier, mechanical removal of the biofilms. Thank you.